influences everything. It's important to recognize pathologies in gait because it really influences how we walk and how we function every day. So everything we talk about with respect to correction depends on achieving a good gait cycle. Heel strike is critical. When we strike with our heel, we take our anterior tibial tendon and we contract it to try to dissipate that force as we load the ground. It's important at that point to have a foot that's unlocked or in valgus so we can accommodate that uneven surface at the same time. So that progression is critical. We want to start in valgus to make sure our foot is unlocked, our shoulder arch joints are supple, so we can accommodate any type of variances in the ground surface. But as we progress on to toe off, we now want to make our foot form a rigid lever. And to do that, the Achilles tendon has to contract, the posterior tibial tendon has to contract to pull the hindfoot into varus. That allows us then to lock our shoulder arch joints and then allows us to push off effectively so we don't have any laxity in that and our gait pattern could subsequently fail. With that in mind, we'll talk about 4 separate types of pathologies: forefoot, midfoot, ankle, and hindfoot. And we'll talk about that with respect to how it influences the gait on some way, shape, or form. We'll begin with forefoot. It's important to recognize that a lot of these tests revolve around correcting bunion deformities effectively. And so to correct them effectively, we have to begin with defining our deformity. Hallux valgus angle is measured first when we look at any type of pathology in the world of bunion surgery. We recognize that angle is measured as the shaft angle of the first metatarsal along with the proximal phalanx, normal less than 15 degrees. The intermetatarsal angle is less than 9 degrees, and that will measure the width between the first and second metatarsals, which gives us a good idea as to what magnitude of correction we require and what type of surgical procedure we will then use. Hallux valgus interphalangeus angle measures the tilt of the great toe in isolation, only important for looking to form a subtle correction at the end of this operation, such as an Aiken osteotomy. And finally, we look at something that's more common now, something not thought about 15 or 20 years ago, and that's the distal metatarsal articular angle. That angle is done to measure the slope of the first metatarsal head. We'd make this angle by measuring first a line across the shaft of the metatarsal and then dropping a perpendicular to that line, then making a second line directly along the axis or plane of that joint surface itself. It is that angle that allows us to establish whether we have a congruent or incongruent bunion deformity, which we'll talk about right now. So we recognize that there are 3 different types of bunions. Congruent bunion deformities have a matched slope of the metatarsal head to the proximal phalanx. You can see it here in this X-ray illustration. It's important to recognize that they have high DMAAs because that slope of the metatarsal head is increased. Incongruent joints have a lower DMAA. This is a more traditional bunion, something that you're more used to, and has a joint that doesn't match. And finally, we have arthritic first metatarsal phalangeal joint bunion deformities, which are treated in a little bit of a separate category. This entire construct matters because we want to, when we finish our bunion correction, to have an absolute congruent joint. If we create an incongruent joint through our bunion correction, we wind up getting significant stiffness and pain and arthritis in that joint surface. So taking a step back, we have a patient with an incongruent first metatarsal phalangeal joint, a stable first metatarsal cuneiform joint, and a lower intermetatarsal angle. In that patient population, we correct it through a distally based osteotomy, which allows us to shift that metatarsal head laterally and then artificially correct that significant intermetatarsal angle. Now we say 13, that's a relative number. Sometimes there are studies out there that shows that we can actually correct larger intermetatarsal angles, but by and large the rule is to use something less than 13 is a distally based procedure. If we have a larger intermetatarsal angle, we instead choose some kind of a proximally based procedure to make up for that. It doesn't matter which type you choose. It can be a scarf or a Ludloff, an opening wedge osteotomy. What matters is the apex of this correction allows adequate alignment of that first metatarsal, which then corrects that bunion deformity overall once it's complete. And the third type of incongruent bunions are those that have a so-called hypermobile joint. These patients have generalized ligament laxity, like a thumb to forearm test, which is positive, or they can hyperextend their elbow. These patients are an entirely different pathology from what we just talked about. These patients instead require a fusion of their first metatarsal cuneiform joint or a Lapidus procedure to perform stability across that interface. Interestingly, in this patient population, orthotics have value. Orthotics don't help many patients with bunions, but those that have a hypermobile joint, that medial column posting in an orthotic takes the tension off of that unstable joint, derotates that bunion, and subsequently fixes the problem. Like I said from the beginning, it's very important when we finish a bunion correction that we establish a congruent joint. If we leave the OR with an incongruent joint, the toe is stiff and becomes arthritic. So whatever that requires, if we're doing a distally based procedure, we might have to correct a biplanar chevron osteotomy, which takes a little bit more bone, medial than lateral, to tilt that head back to neutral. Or if we're doing a proximally based procedure, like you see illustrated here, we may have to make a secondary metatarsal head osteotomy to derotate that metatarsal head and reestablish congruence once it's all done. The final category I talked about was a degenerative or arthritic first metatarsal phalangeal joint with respect to a bunion deformity. Those patients all end up with a first metatarsal phalangeal joint arthrodesis, and fortunately, that allows auto-correction of the intermetatarsal angle, so we have to do nothing else. We don't do a proximal osteotomy with it, we don't do a lapidus with it, we just do a first metatarsal phalangeal joint arthrodesis, and we correct this entire pathology in doing so. Speaking of arthritis, we have hallux rigidus in the forefoot as well. It is the second most common condition in the first metatarsal phalangeal joint and basically translates to stiffness of the great toe. We have different grades of this, which helps us to decide what surgery works best for this patient. We know grade 1 are simply stiff first metatarsal phalangeal joints without a lot of osteophytes or spurs impinging across that interface. We have grade 2s, which are more common and more commonly tested, and those have osteophytes present with some joint space still preserved. And grade 3s are those toes with severe arthritic changes, joint space collapsed across the interface, as well as these large osteophytes present dorsally, and those are treated differently than grade 1 and 2. If we look at anything conservative in the forefoot that has some type of an arthritic condition, we want to stiffen the plantar surface of that shoe in some way. We might make a steel shank that accommodates that and prevents that bending stress from creating flexibility in the toe, or we can do that artificially with an insert, a carbon fiber insert with the so-called Morton's extension, which prevents that dorsiflexion bending of the first or second metatarsal phalangeal joint and takes the stress off that and eradicates then the arthritic symptoms. Remember this, for any type of forefoot pathology that's arthritic, we do some type of mechanism like you see here to stiffen the bottom of the shoe. If we look at this operatively, in those patients with grade 1 disease, we perform a chylectomy, which is nothing more than shaving the dorsal 1/3 of the first metatarsal head, which eradicates that prominence and allows flexibility. But if we have grade 3s, those that are grossly arthritic that I talked about before, those patients buy a first metatarsal phalangeal joint arthrodesis to stabilize the toe and eradicate those arthritic symptoms. Now again, when I was younger, we did Keller arthroplasties for those patients, which was simply nothing more than taking the base of the proximal phalanx and throwing it away. That unfortunately led to instability at the level of the first metatarsal phalangeal joint, transfer metatarsalgia to the lesser metatarsal heads, and it failed because patients had a lot of lateral overload and difficulty walking. So nowadays, that operation is only reserved for someone very elderly or low demand. We look at turf toe. That's an athletic injury occurring from a forced dorsiflexion injury to the first metatarsal phalangeal joint. It's an avulsion of the plantar plate, and subsequently, if it's a complete rupture, proximal migration to the sesamoids, an important point to know, and we'll talk about it in a second. This is a traumatic injury that occurs in some way, shape, or form from that forced dorsiflexion that creates subsequent pathology that can become devastating for the athlete, or specifically the running athlete. There are a variety of grades of turf toe. Grade 1 is treated very simply by immobilization, as is grade 2. Those are simple sprains of the great toe where we have some type of small rupture to the ligamentous complex, not complete, or just a simple injury with a lot of swelling and bruising. If you're a grade 1, you're taped for 2 weeks, then you get back on the field. If you're a grade 2 with more of a partial strain, you're taped for 6 weeks, then you go back playing again with the toe taped. And again, like I said before, you want to stiffen that forefoot with that steel shank to try to prevent that bending stress from creating re-injury. If you're a grade 3, though, that's a very different animal. In that patient population, we see at least 3 millimeters of proximal retraction of the sesamoid. We might take the toe under fluoroscopic imaging and see the sesamoids aren't moving as we move the toe up and down. And in that patient population, they warrant a repair of that plantar plate. If you don't repair it and you leave it alone, you wind up with a so-called cock-up toe deformity, which is miserable for a professional athlete, especially a wide receiver, or someone that sustains this type of injury, because they can't run anymore. They end up getting a lot of pressure off the forepart of their foot, and they have difficulty doing their athletic activities. So it's important to recognize that if you see a grade 3, repair it early. Lesser toe deformities are those that we see, and it's simply rote memorization. A hammer toe deformity is extension at the metatarsal phalangeal joint, flexion at the proximal interphalangeal joint, and extension at the distal interphalangeal joint. The claw toe deformity is the same, except now we add flexion of the distal interphalangeal joint, and the mallet toe is isolated flexion of the distal interphalangeal joint. There's another toe deformity you have to think about as well. This is a coronal plane deformity of the digit, which we see because there's multiplanar or multidirectional instability of that second metatarsophalangeal joint. In that patient population, they have some type of disruption of the ligament complex, whether it be the plantar plate where it all starts. It eventually migrates to the weakened collateral ligaments of the digit. If those ligaments start to attenuate, then the second toe starts to drift over the great toe, and that is subsequently then called a crossover toe deformity. Very different as a part of this process. They may have a tertiary claw toe as a part of it as well, but recognize that that deformity creates a secondary problem you have to address. If we do have claw toe deformities, we look at them as rigid or stiff that we can't correct, or flexible, those that we can correct. If it's a rigid deformity, we end up fusing in some way the proximal interphalangeal joint to maintain that stiffness in combination with soft tissue procedures. If it is a flexible deformity, if we can straighten it out, then we don't do any bone work. It's all done through tendon transfer procedures such as a Girdlestone-Taylor, where we take the flexor and we transfer it to the top of the toe that pulls it back down and straightens it out artificially because of that. If we have a mallet toe deformity, fortunately, fixed and flexible is treated the same. We perform a resection arthroplasty of that distal interphalangeal joint with a tenotomy of that flexor tendon to get that to straighten out sufficiently. Claw toe deformities are treated very similar to hammer toe deformities, except now we add pathology at the metatarsophalangeal joint. And we have to shorten that to decompress that joint and realign that as well. And in flexible deformity, again, it's very similar to what I talked about before, tendon transfers and soft tissue lengthenings. If it's a fixed deformity, we add some type of distally based osteotomy to the metatarsal to shorten that, decompress the joint, and allow it to restore or reestablish an anatomic position. That's similar to what we see in crossover toe deformities as well, because as I said before, there's significant pathology to the metatarsophalangeal joint. Now with that multidirectional instability, we have to find a way to pull the toe back out straight so it's no longer drifting over the second toe. We do that through a variety of tendon transfers. Generally we use the extensor brevis. We weave it deep to the ligament, and that pulls the toe back over to maintain that anatomic alignment. That's done in conjunction with the standard procedures that we talked about with claw toe deformities. But if it's rigid, if I can't simply passively correct it, then I have to do just like we talked about before. I have to take that metatarsal itself and shorten it to decompress the joint and allow it to articulate more effectively. Freiberg's infraction is a variety, is an alteration, or say a sort of a variation of arthritis. What it is it's an infraction, right? And an infraction is an ischemic process that basically allows this to occur precipitated by trauma in some way. It eventually can become an infarction or complete necrosis of the bone, but in the beginning it starts as an infraction. It has a very predictable progression when it occurs. We know that we begin with central resorption of the metatarsal head, then it progressively collapses over time to the point where we've got a significant arthritic second metatarsophalangeal joint. Conservative, we talked about it before. We take some way to stiffen the forepart of the foot with a carbon fiber insert, a Morton's extension, preventing that bending stress from occurring, and then taking the stress off of that second toe, stiffening it. Remember that. Operatively, we want to go ahead and first begin with some type of joint debridement, removing all of that bad tissue around that site, and then we want to get good cartilage present at the level of that joint surface itself. Well, fortunately, in Freiberg's infraction, it rarely affects the plantar cartilage here. So instead what we do is we do a dorsal closing wedge osteotomy of that metatarsal head itself and derotate that plantar cartilage to let it articulate normally across that interface. We never excise the metatarsal head in isolation. In fact, in all of foot and ankle, never take out an isolated metatarsal head, because invariably you will create transfer metatarsalgia to those adjacent to it and then create subsequent pathology there as well. And that is Freiberg's infraction. A bunionette deformity is the opposite of a bunion. Now we have pathology on the fifth metatarsal head. We used to call those Taylor's bunions because really what occurs here is bursitis over a prominence on the outer border of the foot. That bursitis can occur because Taylors used to sit cross-legged on the floor, then they'd wind up getting friction over that bump. That would become inflamed and subsequently symptomatic. There are three types of bunionette deformities as well. There is a type 1 deformity where there's simply enlarged metatarsal head without much of a change in width between the fourth and fifth metatarsals. There is a type 2, which is a congenital bowing of the shaft itself, again creating more widening between the fourth and fifth metatarsal heads, and a type 3, which is more traditional like the bunion deformities we talked about before, where there's a true widening between the fourth and fifth metatarsal shafts themselves. Again, we talked about before, we don't take out metatarsal heads for bunionette deformities, just like we don't do it for Freiberg's infraction. Instead, we do something for osteotomy, just like we do on the medial part of the foot, to decompress that surface itself. We also don't do simple shavings for that same reason that we don't do shavings or silver bunionectomies on the inside border of the foot. In this case, we do a chevron osteotomy, which is limited by the width of that metatarsal shaft. Because that shaft is so thin at the fifth, we can only shift it 3 to 4 millimeters and gain only about 3 to 4 degrees of correction because of that. Type 2s and 3s are treated the same, so you don't really have to recognize which one you have in a test question. We go ahead, though, and make sure when the widened intermetatarsal angle is present, we treat that through a mid-shaft osteotomy of that metatarsal shaft itself. We want to go ahead and derotate it. We can change the angle of our blade to lift this up a little bit or plantar flex a little bit, depending on the position of the fifth metatarsal, but allows us to truly decompress that surface, done in combination with a medial collateral release to straighten out the toe. Unlike what we talked about in bunion deformities, we don't do crescentic or proximal osteotomies on the side of the bunionette. Why? Because we're essentially devascularizing that shaft, creating a true Jones fracture across that site, and there's a high non-union rate because of that. So make the osteotomy in the mid-shaft instead. Morton's neuroma is a dilated nerve generally between the third and fourth metatarsal heads. There, in fact, is located in that region, and there's a lot of pathology on the bottom of the foot that we already talked about. We know we've got the plantar plates here that can create those crossover toe deformities, so it's important to find a way to examine for Morton's neuroma that's very specific in that interspace between the third and fourth or second and third metatarsal heads. So we choose the Mulder's click test, which allows us to essentially deliver that neuroma to the dorsum of the foot between the metatarsal heads, and then we squeeze them together as we're delivering that nerve to the plantar surface of the foot, and that creates a click and subsequent pain that radiates into those digits. That's the diagnostic test for Morton's neuroma. If we treat them conservatively, we obviously have to modify our shoe wear. We need a wider toe box shoe that puts less stress on that nerve. We avoid high heels, which drives that nerve into the ground, and we can try cortisone injections, though we recognize that only about 14% of patients get relief after that first injection, so multiple injections tends to create more structural pathology rather than helping this patient in the end due to ligament laxity from that repetitive use of cortisone. If we're getting into trouble then and it's not getting better, we instead consider surgical excision. For a primary Morton's neuroma, that's done through a dorsally based surgical approach where we resect that nerve and remove it about 3 centimeters proximal to the metatarsal heads. It's critical to clean out all of that neuromatous tissue through this approach, because if you leave something there, it's quantified as a recurrent neuroma, which more often than not is just retained tissue on the bottom of the foot that wasn't excised at that first operation. Now we have to go to the plantar surface of the foot, create a much longer surgical scar, and treat that as a true neuroma, excising that nerve tissue and burying it deep into the muscle belly on the bottom of the foot. Final topic in the forefoot is fifth metatarsal fractures. We know, in fact, there's an anatomic description by zone where these fractures occur. Zone 1 fractures are avulsion fractures, and those occur from some type of a tension that is applied to the fifth metatarsal base. It's not normally the peroneus brevis tendon that causes that avulsion. Instead, it's the lateral band of the plantar fascia that pulls that piece of bone off and creates a subsequent deficit. These are normally treated conservatively in a boot, but occasionally they require operative treatment, but only for a rotated fragment. In my 20 years of orthopedic practice, I've probably operated on 4 or 5 of these only. So it's extremely rare, and for certain circumstances, that those require surgery. They must be distinguished from zone 2 injuries, which are the so-called Jones fractures. These are treated differently depending on the type of person that sustains that injury. If you are an elite athlete and you need to get back on the field sooner, we use intramedullary screw fixation to course over the course of that fracture itself, compress it, and allow it to heal sufficiently. If you're someone who's not an elite athlete and you have some time, those patients are more often treated conservatively. So you can treat Jones fractures conservatively by making them non-weight bearing anywhere from 6 to 8 weeks and then allowing them with progressive weight bearing thereafter. It's very important with any of these types of fractures that have difficulty healing, make sure you get a CT scan before you allow them to return to play to make sure your fracture is complete. Often, a recurrent Jones fracture does not occur because it's a new injury. It's really an old injury broken through a fracture which never really healed. So get the CT scan. The other important point, with any lateral pathology to the foot, fifth metatarsal fractures, peroneal tendon injuries, ligament sprains, look for hindfoot varus, especially on your test question. I'll try and trick you up on that. If you see hindfoot varus, make sure you add a calcaneal osteotomy to realign the hindfoot and take the tension off the outer border of your foot or the athlete's foot before they return to play. In addition, there are zone 3 fractures, which are treated very similar to zone 2. They're a little bit more distal. They're in that watershed zone. And again, same concept. Elite athletes have screw fixation to get them back on the field. Though even in this case, there's a much higher rate of non-union since it is in that watershed area. And so because of it, non-operative treatment is less often performed for zone 3 injuries as opposed to zone 2s that we talked about again. And again, look for hindfoot varus in that population. Let's move on to midfoot. In midfoot situations, we have to first look at the foot as 3 separate columns. In order to assess these columns, we do what we call the piano key test. The piano key test is simple. We take each metatarsal and we move it up and down just like you would a piano key. And that will elicit specific pain at whichever joint may be structurally involved. This is a good test because basically when you do an x-ray of the midfoot, you see arthritis everywhere and it's hard to discern which joints are symptomatic. The piano key test allows you to do that by testing each joint surface in isolation. The column theory I talked about before, the medial column gets about 3.5 millimeters or mid-grade of dorsal plantar motion with manipulation. The middle column has much less than a millimeter of motion across that site, but ironically it's the most symptomatic column in the mid portion of the foot. The lateral column gets 13 millimeters of motion across that site, the most mobile and yet the least symptomatic in the world of arthritis in the mid portion of the foot. If we look at conservative care, again, we're talking about foot arthritis. When we have an arthritic condition, we want to make the sole of the shoe stiff. It has no bending stress about it, unless it takes the tension or stress off or compressive stress off of those arthritic joints. However, in midfoot arthritis, we now can add an orthotic, which is not as effective in forefoot arthritis. The orthotic we make here for midfoot arthritis must be made of plastizote, a very soft material that allows accommodation of activities and takes stress off of those joint surfaces while not trying to overcorrect. If you try to overcorrect and push it up more aggressively, you'll wind up getting increasing pain across that mid portion of the foot. So use plastizote, make sure it's soft, make sure it can accommodate the ground surfaces in doing so as a conservative care option. Arthritic changes in the midfoot are treated by arthrodesis. It's important that we reduce the deformity when we do this arthrodesis. And the other important rule to recognize is we only fuse the middle and the medial columns. The first, second, and third are the only ones that we fuse because those are expendable joints given their limited motion. We talked about in the beginning that the lateral column has significant mobility in it, 13 millimeters of dorsiflexion, plantar flexion movement. We want to maintain that mobility in the postoperative phase, so we use either an anchovy procedure or an arthroplasty like you see here, try to decompress that joint surface, maintain mobility, and eradicate the arthritis at the same sitting. There's only one other midfoot topic fortunate to speak of, and that is the Lisfranc injury. We know that the Lisfranc injury is a plantar-based ligament between the medial cuneiform and the base of the second metatarsal. Being a plantar-based ligament, it is subject to excess stress. When we see or suspect a Lisfranc injury, we are obligated to get weight-bearing x-rays of both feet. Despite the fact it's acute trauma, we want to know how much shift we have and where it is occurring in that portion of the foot. So we get bilateral weight-bearing x-rays of the foot. We assess for any gapping present at not only between the first and second metatarsal bases, but also the cuneiform site, because that now is a variant that we must discern to make sure we correct at the same time. Equally important on x-rays, we look for the so-called flex sign. The flex sign is a bony avulsion fragment, generally from the medial cuneiform, that is actually a good sign to see here because generally then the ligament itself is still attached to that piece of bone that avulses. These do better than pure ligament Lisfranc injuries, and we'll talk about that in a second. If we get a weight-bearing x-ray like you see here, and we see no evidence of gapping between the cuneiform site or the metatarsal bases, we instead get an abduction stress x-ray. We manipulate that foot, and we look for a gapping present, and again, that's our only way to securely say that there's no evidence of severe injury to that ligament complex in the mid portion of the foot. Studies looking at Lisfranc injuries show that the operative treatment results are directly related to your anatomic reduction. So in the book it says if there's more than 2 millimeters of displacement, fix it. We would say that if there's any visible displacement, fix it, and that fixation is done through screw fixation. we know that the Lisfranc screw is placed from the medial cuneiform into the second metatarsal base. But like I said in the very beginning, also look at the intercuneiform joint surfaces, for if there is splaying at that site, that must be addressed simultaneously to restore the normal architecture of the foot. Now in this day and age, we look at these so-called bridge plates, which traverse these joint surfaces themselves. It's become offensive to put screws across the first and second metatarsal bases. I will tell you that there's not really any literature yet that shows that. Those patients have better outcomes, but it is a trend towards avoiding violation of the cartilaginous surfaces, which makes sense in the world of orthopedic surgery, which is why we're doing it. But again, there's no statistics that show that that does functionally better than the older techniques of having screws traverse those joint surfaces themselves. Like I said before, we want to maintain our mobility of the lateral column, a fundamental theme in arthritic pathology of the midfoot. So in this case, we don't put plates or screws across the lateral column, the fourth and fifth TMT joints. Instead, we use K-wires, which traverse those joint surfaces, and then we pull those early to allow that mobility to be maintained. Most of the stability comes from the medial column regardless. One additional point, we know in the world of Lisfranc injuries, like I told you from the very beginning, pure ligament Lisfranc injuries don't do as well as those that have a bony Lisfranc injury in some way, shape, or form. So there's been one randomized prospective study that evaluated outcomes in pure ligament Lisfranc injuries, whether they were fused at the midfoot or instead if they were treated by traditional methods. And that study found with a statistically significant difference that patients did much better with an arthrodesis of the midfoot rather than joint preserving operations that I just spoke about to treat that same pathology. So if you have a test question that looks at pure ligament Lisfrancs, we treat those primarily through arthrodesis based on this study. Let's move on to the hindfoot. In the world of hindfoot, we have a variety of bones here that we must make articulate. Now we're getting into that region that it becomes extremely important, going back to that gait discussion I gave you before, to make sure we achieve a balanced foot once we're all done. The accessory navicular develops from some type of secondary ossification center off of the base of the navicular. The incidence in the general population is about 10%. It's most symptomatic after some type of traumatic incident that creates an avulsion of that bone off of that region where it has a synchondrosis between the natural and navicular bone. There's a variety of key studies radiographically that I'm about to talk about. I just did when I talked about Lisfranc injuries. I said get bilateral weight-bearing x-rays of the foot. Now in the world of navicular, we want to make sure that we get an external oblique foot radiograph, not the traditional internal oblique. We're getting an external oblique foot radiograph because that will specifically allow us to assess the accessory navicular while at the same time allowing us to see if it's got a little synchondrosis there and if it's separated because of that. We can also see these on lateral radiographs, although it's much more difficult to tell where the accessory navicular is, so make sure that you tell your technologist to get an external oblique radiograph to look for an accessory navicular. The treatment for this primary is immobilization. All foot pathology really is, but if that fails, we talk about surgical procedures to correct. In the world of accessory navicular, generally type 2s, which have that synchondrosis disruption, we do a modified Kidner procedure where we remove that affected bone and we go ahead and advance the posterior tibial tendon over that site to reestablish the normal mechanics of that foot by enhancing the pull of the posterior tibial tendon. There are some authors that may argue that we should try and fix that bone. You can certainly answer that as a test question if it's only a choice between that and nothing else. But still, it's generally accepted that the modified Kidner procedure has a higher success rate given the union is difficult to achieve between that small piece of bone and the natural navicular body itself. Speaking of the navicular, we also look at navicular trauma. We know that the central portion of the navicular is avascular and it's subject to stress fractures and non-union because of it. The difficult part is this diagnosis is hard to make in patients with navicular trauma. Generally, they come in and they complain of some kind of vague dorsal aching pain with activities only, and it's not very specific. You feel for the so-called end spot right over the navicular itself, and if you push in that area, they elicit specific pain in that zone. And then, if you do get pain, then you can evaluate your radiographs. If you see nothing in that case, you get an MRI to look for edema in the bone itself. But if you see a subtle crack, you're obligated to get a CT scan. That's your diagnostic test for navicular trauma, because now we want to assess not only the fracture itself, but the width or gap between it to determine if it's an operative or non-operative circumstance. Conservative care for navicular fractures is extremely rare. In fact, we talk about complete non-displaced injuries being the only ones that would warrant this type of conservative care. Most navicular fractures are displaced, and so most of them warrant some type of surgical reconstruction. I will tell you that if you do perform conservative care for this, we make them non-weight bearing for a minimum of 6 to 8 weeks, and then we must get a CT scan to make sure that that bone has united sufficiently before we allow them to progress on to the normal activities thereafter. We don't want to get a recurrent navicular fracture, and thus it's critical. If we have any displacement, 1 millimeter, 2 millimeter, whatever on our CT scan data, then in that case we do screw fixation. Those screws run from lateral to medial. I told you before about the plane of that fracture and where it runs. Now we can't make those screws particularly perpendicular to that plane because that plane is dorsolateral to plantar medial. If we try to put screws way down low here to go perpendicular to that plane, we wind up causing blockage with the cuboid, and they're very difficult to place. So instead in navicular trauma, though they go lateral to medial, they still go more dorsolateral to plantar medial just to gain compression across that site. And that's always a question people ask me about, and that's why. If we have a chronic navicular fracture, we then open it up and bone graft the margins and give it a chance to heal sufficiently. And again, like I said before, with conservative care, a CT scan is always required before you allow that athlete or individual to return to play or use it. The navicular is like a nutcracker effect. Every compressive stress across it can create further fracturing and fragmentation, so that bone has to be solidly healed before that athlete can get back in the game because of it. Tarsal coalition occurs because of a failure of differentiation and subsequent lack of joint formation. There are a couple of varieties to speak of. The first being the talocalcaneal coalition, and the second being the calcaneonavicular coalition. They're roughly about 50-50 with respect to incidence, and it's important to note that you may have this and not even know about it. It frequently doesn't present until you sustain an ankle sprain or some type of trauma across that site. In patients that have a tarsal coalition, we recognize that. Again, we have key radiographic views to look for. We always get a lateral weight-bearing view to look for this so-called talar beaking, which can occur because of lack of rotation or varus valgus tilt to the hindfoot, which creates subsequent stress at the talonavicular joint and those osteophytes developing. If we suspect a calcaneonavicular coalition, we now get an internal oblique X-ray of the foot. Not external, like we talked about with the accessory navicular. Now we get an internal oblique because we can define carefully whether we have a calcaneonavicular coalition. The key radiographic markers, if you suspect a talocalcaneal coalition, is a Harris axial view. That will show you the middle facet and as such give you good information as to whether that coalition is complete or partial because of it. If we treat these operatively, it involves resection of the coalition itself. We know that if we have a younger individual, less than 14 years old, symptomatic cases, more often they wind up with resection of the coalition with bone wax interposition. There was a study done years ago that said that if you have more than 50% of the joint that's fused in the tarsal coalition, that you should fuse the rest of it. Go ahead and do an entire subtalar fusion in those patients that have a coalition of the subtalar joint or talocalcaneal coalition. But it's important to note that 50% involves the total articular anatomy of the hindfoot and the posterior facet. So if you have a patient that has a complete coalition of the middle facet, that still is very small in comparison to the total articular anatomy of the posterior facet and the anterior facet, and those patients don't warrant fusion. So when you make that assessment, make sure you understand that it's the total surface of greater than 50% that then warrants fusion of the subtalar joint. Tarsal tunnel syndrome is a compressive neuropathy to the tibial nerve. Multiple causes. You can have some type of space-occupying lesion, engorged veins, or some type of mass that occurs pressing on that nerve in that very tight zone in that region. These patients, like navicular fractures or navicular stress fractures, have a very diffuse symptomatology. They basically complain of some type of diffuse burning pain on the plantar surface of the foot that creates this type of irritation across that site. The diagnostic modalities, we know that the two-point discrimination is probably the earliest disturbance that you will see in this population, so start with that first on the plantar surface of the foot, assessing both the medial and lateral plantar nerves. We know, in fact, that an MRI is appropriate in these individuals to make sure that they don't have a space-occupying lesion. We're looking for a schwannoma because they have much better results if they have nothing visible on their MRI. Operative occurs, again, for failure of conservative care. They fail a medial post-orthotic. A lot of patients with tarsal tunnel have a bad valgus deformity, and that puts tension on that tibial nerve on the inside border of the foot. If we give them an orthotic, we try and decompress that region where the tibial nerve is under tension, but if that fails, they wind up getting a decompression, which you can see is through a long incision. It's not a very small incision. We want to make sure that we release the entire tarsal tunnel all the way down the first branch of the lateral plantar nerve. And in fact, the best results are seen in those that have a mass. If you have a schwannoma or a neurolemoma, you have a greater than 90% success rate with tarsal tunnel surgery. If there's nothing in there except for engorged veins, the success rate drops to about 50%, and you must counsel your patient on that before you begin the operation. Now here come my two favorite topics in the world of foot and ankle. The first is adult-acquired flat foot deformity. We know that adult-acquired flat foot deformity comes from some type of posterior tibial tendon pathology. We recognize that the posterior tib has a hypovascular zone where the blood supply is compromised about 2 to 6 centimeters proximal to the insertion of that tendon and about 14 millimeters in length. That occurs right where that tendon courses behind the medial malleolus, and the repetitive friction can create irritation of that tendon over time. We know, however, that the ultimate failure is the spring ligament. You can cut the posterior tib and let the patient walk, and they don't immediately develop a flat foot deformity because of it. It's that repetitive stress on the spring ligament that eventually creates that flat foot deformity progression and subsequently causes the deformity to go into abduction and rotation into the deformity we're used to seeing in those patients with posterior tib pathology. A simple test, like we talked about from the very beginning in the world of gait. We do a single toe rise. When you go up on your tiptoes, you have to pull your posterior tibial tendon into inversion to lock your show parts joints and allow you to go up and down on your single tiptoe. That's why that test is so valid. We know, in fact, that if the tendon is intact or competent on some level, you can easily do a single toe rise to accommodate. You can do that rigid lever for a push-off because of it. The tendon itself has a very small excursion. It only moves about 2 centimeters within that tunnel. So if there's any type of deficit within it, it compromises it enough to not let it create that rigid lever, and patients don't get that varus tilt and subsequent ability to go up on that tiptoe. So we can look at flexible versus rigid deformities because of that toe rise deformity thereafter. Conservative care revolves around an orthotic, and that orthotic used depends on how bad the disease is. If it's a very early condition with some mild abduction deformity, those patients get a medial post-orthotic. If they start getting lateral column symptoms at the fibula interface with the calcaneus, now we have to derotate the calcaneus as well, and those patients get a UCBL, or University of California Biomechanics Laboratory orthotic, to subsequently support the calcaneus and avoid that subfibular pain. If it's further along the line, now they've got stage 3 disease, which is rigid and arthritic, they get a so-called lace-up brace across the site, or a zona brace, to give them enough stability present and eradicate that subfibular pain. And if now they have ankle pathology in later term posterior tib insufficiency, they wind up getting an ankle foot orthosis to correct the entire construct. So we talked about stages. If we have simple tenosynovitis or something where there's inflammation in the tendon itself, we can do a tenosynovectomy. I will tell you that that's extremely rare. You have to give these patients about 6 months of physical therapy before you put them into that category. Those patients have failed orthotics, they've failed physical therapy, they've failed transient immobilization, and when you do a tenosynovectomy, you're obligated to look at the undersurface of the tendon, because the undersurface of the tendon itself will show you whether there is an actual pathology present or split tearing within the tendon itself, which then would cause potential progression to a stage 2 deformity. It's extremely important to discern stage 1 versus stage 2, because under those circumstances then you can get a much better outcome. Stage 2 now, we still have a flexible deformity to the flat foot itself. We can still passively correct the deformity. They have an abduction deformity, and they progress on to subfibular impingement as that disease progresses. In the early stages, we treat them with eradication of the posterior tib itself. Once that tendon has fissuring and structural pathology and length deficits, it's no longer a valid tendon to use. And so in this case, we do a flexor digitorum longus tendon transfer, where we take the FDL and we transfer it to the navicular to create a new tendon on the inside of the foot. We recognize that the FDL is only 1/3 as strong as the natural posterior tibial tendon. So we have to do other procedures to complement what we're doing in that tendon transfer. In earlier stages, we do a medial slide calcaneal osteotomy, where we take the calcaneus and we shift it about 8 millimeters or 1 centimeter medial to take the structural alignment of that and realign it out of the valgus deformity, while simultaneously taking the Achilles tendon and translating it medially to support the tendon transfer that I just talked about. So it has 2 separate functions because of it. If we have a later term disease, now the foot shows significant abduction. Now they talk about in a test that they have subfibular impingement or significant collapse or abduction. Those patients now warrant a way to correct that structural deformity. So in that population, we had a lateral column lengthening, or Evans procedure, where we open up the calcaneus itself through a separate incision and we place a bone wedge in to crank it around and reestablish the congruence at the tail and navicular joint. All these stages may have so-called fixed forefoot supination. And in that population, after you correct the valgus deformity, the foot rotates into supination, offloading the first ray. So if they tell you about a patient that has rigid fixed forefoot supination, you have to add some kind of medial column stabilization to depress that arch and allow it to articulate in a better fashion with a standard flat foot deformity. And so in this case, we add either a cotton osteotomy, which is an opening wedge mediocuneiform osteotomy, or if it's a hypermobile, first tarsometatarsal joint, we add an arthrodesis to stabilize that medial column and accommodate that later stage disease where we have that fixed forefoot supination. We talked about even later stages where the deformity becomes rigid. We talked about Arizona braces or lace-up braces to make up for that deficit. If they come to an operative situation, they then warrant a triple arthrodesis. It's important when a triple is done that it's done to correct the deformity simultaneous. You don't want to do a triple and have a rigid deformity present, which is a poor alignment, because you'll wind up getting a more miserable patient than you had when you started with. And finally, we talk about stage 4 disease, where it becomes later stage, and the deltoid ligament now has pathology, and there's tilt to the ankle joint once it's all done. These patients warrant either a deltoid ligament repair, if it's a supple deformity, in combination with everything I just talked about with flat foot correction, or if it's a rigid arthritic ankle, they warrant an arthrodesis to make up for it instead. So follow flat foot deformity along the stages, recognizing that most often you'll be tested on stage 2, which is the supple, flexible deformity still present with some type of length deficit, then utilize the stages accordingly with respect to the operative procedures that I've just described. In every stage, doesn't matter which it is, we have to do a silver scolt test, which is done by measuring the flexibility of the ankle with the knee both flexed and extended. What that does is, with the knee flexed, it allows you to take the tension off the gastrocnemius tendon, since that tendon crosses the knee. If you straighten out the leg and it becomes more tense, that means that you have an isolated contracture of the gastrocnemius tendon. And in that case, we perform a Strayer procedure to enhance flexibility of our ankle after we've had long-term valgus deformity. If you have a negative silver scolt test, in the sense that it has the same amount of lack of flexibility with the knee flexed and extended, then in that case you have to perform a triple step cut or Hoke Achilles tendon lengthening, because now you have to lengthen both the gastroc and the soleus to maintain that flexibility. All patients with long-term valgus deformities get progressive tension on their Achilles tendon because of the relative shortening that occurs as the calcaneus moves more laterally over time. My other favorite topic is cavo-varus foot deformity. We know that is an abnormal elevation of the medial column or the arch. It is essentially forefoot equinus relative to the hindfoot, or a plantar flex first ray that creates the cavus deformity component to this relative to the hindfoot deformity. We have cavus foot deformities that can be treated conservatively with orthotics. We do not get this type of an orthotic you see in the upper right corner, which is a rigid high post orthotic, to match or even try to increase that arch height, because you'll simply push the foot over even further and create even more lateral column overload and subsequent pain. Instead, we get lateral post orthotics that offloads the lateral column and allows them to ambulate more effectively. Half of these patients with cavo-varus feet that are progressive have Charcot-Marie tooth disease. In that case, we know it's an inherited disorder of both the central and peripheral nervous system, and that overpull of an agonist against a weak antagonist causes a progressive cavo-varus deformity to develop. The Coleman block test is a great method to assess the fixed forefoot deformities that you may have. Like I said before, in cavus foot, you have that fixed translation of the forefoot or the first ray into more and more plantar flexion. So what the Coleman block does is it offloads that. If you take your block or your book and you place it lateral to the first ray, you've now freed up your first ray and offloaded it. As the patient applies pressure now on the book, if the forefoot is offloaded and the hindfoot tilts more into valgus or neutral, you recognize that this is a forefoot-driven cavo-varus deformity. It's important to recognize that, because this will depend on how we treat it or correct it once it's done. If we use the Coleman block test and the hindfoot stays in varus after offloading the forefoot, we recognize that it's not simply a forefoot-driven deformity. Instead, there's rigid hindfoot varus commensurate with that. And like I said before, this all helps us out with how we treat it operatively. If we have a forefoot-driven cavo-varus deformity, makes sense. We want to offload the forefoot. So we do some type of first metatarsal dorsiflexion osteotomy or dorsiflexion arthrodesis at the first metatarsal cuneiform joint to lift up that medial column, take the tension off it, and decompress that varus deformity. If they have an incomplete Coleman block test and the hindfoot is still in varus after you've offloaded that first ray, you must add a closing wedge calcaneal osteotomy to decompress that joint surface and, more important, derotate the hindfoot so it now achieves a plantar-grade foot and you eradicate that cavo-varus deformity. All these patients with long-standing cavo-varus develop a tight plantar fascia, just like the pes plana valgus deformity patients get a tight Achilles tendon. So you might have to do a Stindler plantar fascia release to decompress that region as well. In addition, because I talked about before the agonist-antagonist behavior, you may also have to add a peroneus longus to brevis transfer, because the longus is the agonist pulling tightly on that portion, the brevis is weak, and the longus to brevis transfer supplements the lateral column pull and reestablish a more natural or neutral deformity. Peroneal tendons themselves also require operative repair sporadically. We know that simple tenosynovectomy is done in patients that have fissuring or tears of the peroneal tendons themselves. We recognize that, however, that if over 50% of the tendon diameter is violated, we then have to add some type of tendon transfer to supplement this repair. If the longus is good and the brevis has a greater than 50% tear, we do a simple brevis to longus transfer. If, however, both the longus and brevis are affected and neither are working well, we instead have to find a new tendon to make up for that deficit, and we use the flexor hallucis longus tendon transferred to the fifth metatarsal base to make up for both peroneal tendons being absent or ruptured or in bad shape. It's an important point to know that for any peroneal tendon pathology, and like I'm about to talk about, any Achilles tendon pathology, we use the flexor hallucis longus as our workhorse tendon to make up for it. And like I said before, in both circumstances, any lateral pathology to the ankle and hindfoot, evaluate for hindfoot varus. Heel pain, often considered with plantar fasciitis, recognize that conservative care is the rule. 95% of patients get better with simple stretching protocols, including night splints to elevate that portion of the foot and take the tension off the, or actually increase some tension on the plantar fascia in combination with the stretching exercises that we talk about. Cortisone injections have very limited value because repetitive cortisone injections can cause rupture of the plantar fascia over time. In addition, we can consider operative intervention in these patients, but before doing so, we may consider shockwave treatment to treat plantar fasciitis. Success rate's only about 50% or so, but it may have some value in preventing you getting to this operative stage. In the older days, we used to cut the entire plantar fascia. Now we recognize that causes a significant flat foot deformity, so in this day and age, we instead remove only about a quarter of the plantar fascia immediately, and most important, we decompress the first branch to the lateral plantar nerve, or so-called Baxter's nerve, because that nerve creates irritation at the heel as well, as it's pinched in that deficit on the plantar heel. So we might remove the heel spur, but the heel spur itself is not the driving or offensive force. But like I said before, consider shockwave before you move to this, recognizing that all results in this category are not terribly that great. And finally, also think about tension on the Achilles tendon complex. Again, the same thing I told you about before with the knee flexed and extended, doing the silver skull test, and consider a Strayer procedure, again, to offload that plantar fascia on the bottom of the foot. It's important to note that this must be discerned from calcaneal stress fractures. To test that, we do a squeeze test to the calcaneus and see if it elicits new pain. If that's the case, we treat it very differently. We might see a fracture line perpendicular to the orbicular bone, or we get an MRI because it'll show edema in the whole body of the calcaneus or the posterior tuberosity. In that case, we cast these patients. We do not put them through a typical physical therapy protocol because you'll cause more irritation and make them more angry when it gets done. So make sure that you discern calcaneal stress fractures versus plantar fasciitis. Stress fractures immobilize, plantar fasciitis move. Ankle. We know that the Achilles tendon disorders occur posteriorly. We know that the retrocalcaneal disorders revolve around insertionally at a Hageland's exostosis. This so-called bone spur creates insertional tendinopathy over time, which makes it difficult for these patients to walk and do functional activities at the insertion. Remember, no injections at the Achilles tendon complex. Studies show over a 50% risk of rupture of the Achilles tendon, even for simple bursal injections of cortisone into that site. Operative treatment, if we see no evidence of insertional tendinopathy, but we have the so-called Hageland's exostosis, we do a simple resection of that through an oblique incision done either medial or lateral to eradicate that disease. However, if we have significant tendinopathy, if there's spurs present at the insertion, or if you get an MRI and it shows there's significant degenerative changes to the insertion of the tendon itself, you change your strategy. Now you make a central splitting approach to the Achilles tendon, you open it up, You shave all of that disease off the insertion point of the heel, and you must supplement this to allow the patient to function more effectively. And again, like I told you before, for peroneal tendons, use the flexor hiatus longus to supplement. Also, for Achilles tendon, use the flexor hiatus longus tendon to supplement that tendon transfer and give them better push-off. If you have non-insertional tendinopathy, where in fact this is more the intrasubstance or mid-substance portion, where the tendon is dilated and swollen across that site, in that patient as well, that occurs at that so-called watershed zone where the blood supply is poor. Repetitive trauma causes that tendon to form, mucoid degeneration, and poor quality tissue, and that always occurs at the same location, about 2 to 6 centimeters proximal to the insertion of the tendon itself. Operatively, similar to peroneal tendons that we just talked about, if we have excision that's a part of it, we recognize that. We want to remove that diseased tendon and tubularize it, just like we did with the peroneal tendon. But if more than 50% occurs, in that case, we had a flexor hiatus longus tendon transfer to the level of the calcaneus, and that supplements our repair. Remember, FHL, Achilles, and peroneals. For flat foot, FDL, different tendon complexes because of it. Ankle sprains, we know that most of them improve with simple functional rehabilitation. There is no role for acute repair in patients with ankle sprains. 15 to 20% of them can have residual instability episodes. In that patient population, we look at that as either mechanical instability or functional instability. Mechanical is evident on stress radiographs as obvious deficits present in either the anterior fibula or calcaneofibular ligaments. Functional is more of a feeling of it giving away with activities. Fortunately, both of those are treated the same. We do an anatomic repair of the ligament complex for those that have chronic ankle sprains which recur repetitively over time. In that patient, we always start with a modified Brostrom lateral ligament reconstruction, which takes the anterotalofibular and calcaneofibular ligaments and advances it over the lateral wall of the fibula. It is a modified procedure because we don't simply just repair the ligaments. We actually take the inferior peroneal retinaculum and we also advance that over the lateral wall of the fibula to give absolute stability to our overall construct. We can consider non-anatomic repairs where we take either a slip of peroneal tendon or we utilize an allograft tendon to create a newly reestablished ligament complex laterally. Non-anatomic repairs like this, such as a Christmas snook, are valid for large athletes, NFL linemen, revision surgery if your first modified Brostrom failed, or if they are a hypermobile patient. So if they say the patient has a positive thumb to forearm test or hyperextension of their elbows, consider a non-anatomic repair rather than a traditional modified Brostrom as your primary operative intervention. Again, they have a high success rate with a Brostrom. There's much less of risk of nerve damage because of the incision placement. And finally, like I said before, lateral pathology, you must look for hindfoot varus, and if you see it, consider a closing wedge osteotomy to realign that foot and take the tension off all lateral column disease. Osteochondritis dissecans, your best tool for imaging. If you see nothing on your x-ray, is an MRI. But if you see a lesion present on your plain x-ray, get a CT scan. The CT scan allows us to accurately measure the size of the lesion, and as such, with that information, we can give the patient predictive value on how well they're due. If we do see an osteochondritic lesion, we always start with the same method in treatment. It's drilling and microfracture technique. It's always our primary procedure for persistent symptoms. And if they're uncertain, we give the patient the qualification that if they have a lesion larger than a centimeter, then they have an uncertain prognosis. And if we have failure of the OCD drilling and microfracture, only then we consider doing an Oates or mosaic plasty for salvage techniques. And again, the results are better if we don't have to break the medial malleolus in doing that. The final topics are two systemic diseases, the first being rheumatoid arthritis. We recognize that 17% of all rheumatoid arthritic patients are detected in the foot first. That's why this matters. If you see someone with foot pathology that's severe like this, consider rheumatoid arthritis as a part of your primary diagnostic modality. We look at rheumatoid arthritis in a couple different categories. We know first that the forefoot, if we see it, we see subluxation at the metatarsophalangeal joint, these gnarly claw toe deformities, these underlying callousing present, and conservative care is to put a soft insert in the forepart of the foot to offload those metatarsal heads themselves. Operatively, we consider, like we talked about from the very beginning at the world of arthritic first metatarsophalangeal joints, the traditional procedure for an arthritic rheumatoid forefoot with a bunion deformity or significant arthritic changes is to fuse that great toe. This is one time when you can resect metatarsal heads, but you have to resect them all. Like I said before, with Freiberg's or with bunionettes, don't resect isolated metatarsal heads. If you're going to do the Hoffman resection to decompress that part where that metatarsalgia is so bad, you must resect all of them all the way across the board and pin the toes for about 6 weeks to give them adequate stability once it's all done. If we get to the hindfoot condition like this, we consider fusions to realign and balance the hindfoot. If we see someone with a significant arthritic hindfoot, we don't do the traditional posterior tib procedures that I talked about before with adult-acquired flat deformity. Rheumatoids by fusions to make sure that the reconstruction stays, no longer causes a significant structural deficit, and they wind up getting long-term much better results because of it. If the ankle is involved in a rheumatoid disease, the primary treatment for isolated ankle pathology may or may not be, but for your test should be ankle arthrodesis. We put that in a little bit of external rotation and neutral alignment thereafter. Again, a little bit of valgus to unload show parts joints so these patients can accommodate uneven ground. It's really critical as a part of this deal. And we also want to make sure that we preserve the lateral malleolus for a possible late total ankle arthroplasty. And speaking of that topic, it's a very important one because rheumatoids have pathology everywhere. And if you have a rheumatoid that has hindfoot arthritic changes that requires a triple arthrodesis, or if you have the potential for that in the future, instead of considering an ankle fusion as your modality, you would consider an ankle replacement. Because if you do have to do an ankle fusion and a hindfoot fusion, those patients have pan-talar fusions, which traditionally do very poor with gait mechanics. So consider ankle arthroplasty under those circumstances that we've talked about. Diabetes has different types of neuropathy. We know that sensory neuropathy occurs in 90% of patients, and those that have some type of sensory neuropathic pattern over time, we look for this so-called 5.07 Semmes-Weinstein monofilament, which gives us protective sensation when we walk and gives us our best chance to minimize the risk of ulcers developing. Motor neuropathy also occurs. That occurs through the common peroneal nerve, and those patients over time can develop claw toes or hammer toes because of it. And finally, autonomic neuropathy also occurs, which creates dry, scaly skin, which provides portals of entry for bacteria and subsequent infections. So all three types of neuropathy matter. If you see a clean forefoot ulcer without any other pathology surrounding except for bone prominences, we treat this with a total contact cast. We use a total contact cast which envelops the entire foot to minimize shear stress across that ulcer and gives it a much better chance to heal. We recognize that if they have a significant tight Achilles tendon complex with it and the ulcer is in the forefoot, we might have to lengthen the Achilles tendon simultaneously to decompress the forefoot once we're all done. Total contact cast is the first line of defense unless we see a deep infection. If it's an infectious process now, they're often polymicrobial. We use broad spectrum antibiotics initially, and we have to get deep surgical cultures. They're the only ones that matter to make sure we target our specific antibiotics to the specific organism once it's all done. In patients that have Charcot disease, it's often confused with an infectious process. Have the patient elevate the leg for about 5 minutes or so. When they do that, if they have Charcot disease, the redness often goes away. If it's an infectious process, the redness does not go away. You can also get a bone scan and a tagged white cell scan to make that determination. The stages matter in the world of Charcot disease because if it is a Charcot disease itself, we want to make sure we operate in the so-called late stage or the consolidation stage, which may take upwards of 6 to 18 months before the bone quality is sufficient to allow us to do our major reconstructive efforts and rebuild these feet. And we do have to rebuild these feet if they're subject to chronic ulceration refractory to total contact cast care. In these so-called late stage 3 disorders, when we have patients that have these rocker bottom deformities that are severe, we can do surgical reconstructive procedures to realign the arch, to offload that portion of the plantar foot where the bone prominences are significant, and minimize the risk of recurrent ulcerations. These operations are important because if we let these ulcers persist, they will eventually become infection, and that's how we wind up with amputations. So again, it's critical to assess this and do it at the right time at the so-called later Eichenholz stage, the consolidation phase, where this type of procedure is appropriate. And again, make sure we get vascular testing in advance so we know the patient can heal the wounds as well as the bone architecture itself. And finally, note that again, like I talked about with forefoot pathology, if there's tightness in the Achilles complex in a diabetic, you must lengthen the Achilles done simultaneous with it to minimize the risk of subsequent recurrent deformity because of it.